I am now pleased to introduce our first speaker, Rivka Friedman, Group Director for the State Innovations Group and Acting Director of the Prevention and Population Health Group at the Center for Medicare and Medicaid Innovation. In this capacity, she oversees CMMI's work on state-based multi-payer models, as well as Medicare and Medicaid prevention and population health-focused models. We're so grateful that Ms. Friedman is with us today to provide an overview of the Accountable Health Communities model, which is the first CMI model to focus on health-related social needs of Medicare and Medicaid beneficiaries. She'll discuss how the model addresses health-related social needs through enhanced clinical community linkages and how this can improve health outcomes and reduce costs. She'll also talk about a newer model focused on at-risk children and pregnant women. Rivka?
Thanks so much, Catherine, and thanks to everybody at NIHCM for having me today. I'm thrilled to be here with so many folks who are interested in addressing beneficiaries' health-related social needs. As I think you all know, this is an issue of paramount importance for our industry writ large and has relatively recently become an area of interest for CMS and CMMI. I want to spend a little bit of time today talking about really two models that CMMI has developed in this vein, and then perhaps talk a little bit about how we've learned from each of these models, one of which is quite a bit more mature than the other, in thinking about how we at CMMI and we as the broader CMS can address our beneficiaries' health-related social needs. So first, as you can see on the slide here, I think there's sort of a timeline of CMMI engagement in social determinants of health issues that started before 2014, but formally in 2014 when we announced the Accountable Health Communities model, which is a model that funds community-based organizations to screen and navigate beneficiaries for health-related social needs. And the most recent second point on that timeline was in 2018 when we announced the Integrated Care for Kids model, which actually started in January of this year, and which funds communities to establish multidisciplinary care teams for children and pregnant women who are covered by Medicaid and CHIP, who are at risk for a number of different both medical and behavioral health needs. Those are the 2 points on this timeline. I hope that there will be other points going forward, and I also just want to acknowledge again that each of these announcements was the result of a significant amount of work. I think one of the unique things about our work on the Integrated Care for Kids model, or INC, is that we were able to learn from prior experience in AHC. And so I'm hoping to shed some light today on what we've learned from AHC so far and how that has informed future or subsequent design efforts. So, as I mentioned, the Accountable Health Communities model was our first foray into social determinants as a center. And that model represented a key first step for us, and again, was the result of a significant amount of work, we published on it actually twice, first to announce the model and to talk about the evidence base behind it, and then subsequently to talk about a proprietary screening tool that we developed as part of the model that I can touch on later. At the core of the model's intervention is an effort to equip what are called bridge organizations to achieve scale. So the bridge organizations vary in type and in size. Some of them are YMCAs, others are health system related organizations, others are independent organizations in their communities. There are a lot of different kinds of bridge organizations. The core goal of the model is to fund bridge organizations to do a number of different things, one of which, as you can see on this slide, is to connect with social service providers. I think this is the core of the model for a lot of bridge organizations in terms of getting those social service providers plugged in, making sure that there's sufficient capacity of social service providers, and then helping connect beneficiaries to the relevant social service provider given their needs. And I will also just share, again, because we're really in the middle of this model and continue to learn from our efforts every day, that some of what we've heard from bridge organizations really relates to this question of how we scale social determinants related interventions. This is a topic that has come up in our conversations with bridges and AHC. It's a topic that came up in our design efforts for the integrated care for kids model. It also is a discussion that has arisen in other contexts when we've discussed CMMI's potential future efforts in the social determinants space, is that CMMI can serve a number of different roles. We have funding, we have flexibilities that we can offer, and of course, we have our statutory mandate. We at CORE have to help organizations on the ground to build scale and to achieve capacity. We can't build the capacity ourselves. I think this is one limitation of our efforts in this area, but also, again, has been a tremendous source of learning for us. So the AHC model has two tracks. It has what's called an assistance track and then what's called an alignment track. The tracks are quite similar in that in both tracks, bridge organizations are doing all of the things that are listed on the left here. So they're building relationships with clinical delivery sites that are going to implement the model in terms of screening beneficiaries and then connecting them through to navigation. They're developing processes for screening, referral, and navigation. And then in the case of the assistance track, they're also developing processes for randomization because that track is randomized and we randomize which beneficiaries are actually navigated. And then they're hiring and training staff. And I think that goes to what I was mentioning before about the importance of really building capacity. They need to build the capacity at their own site. They need to build the capacity at their delivery sites. And ultimately, I think they're quite motivated to help build the capacity of social service providers. In addition, the alignment track is intended to establish an advisory board to start collecting community-level data on where there are opportunities, again, at a community level to really improve quality and fill key needs that are currently unaddressed. One of the things that we believed when we designed the AHC model that has become even more apparent over time is that we often don't know what we don't know. And one of the goals of the alignment track was to set up some systems in place at a community level for understanding where there were gaps in care that something like a bridge organization or the AHC model could address. I wanted to share a bit of a profile of the awardees that received the funding through the Accountable Health Communities model. As with everything, we have learned a lot from examining the performance and also the challenges that each of our awardees has faced. As you can see, we have quite a range of awardees. So at start of the model, there were 31 awarded communities across 23 states. And they were spread quite a bit geographically. We have representation in the Northeast, the Midwest, the South, the West. We had a mix of urban and rural communities, a mix of smaller and larger communities. And we have learned a lot about the different dynamics in play at a local level and how those inform and affect participation in the model. I will note, just because I think it's relevant to some of the other conversations that are happening nationally now, that it has become apparent that rural awardees of the model struggle with different things than their urban counterparts struggle with, including in particular the ability to achieve scale of clinical delivery sites and scale in terms of processes that work across sites. And that, again, is something that we have heard across other models with a significant number of rural participants, that things can just be more challenging when the population and the set of providers, both healthcare and other, are spread so disparately. So briefly, I wanted to touch on which health-related social needs are touched by this model. I think that certainly recently have started to see some different definitions of health-related social needs emerge. So you can see here the list of our core needs that are addressed by AHC, which are housing, utility, food, interpersonal violence, and transportation. This is the core set of health-related social needs for the model. And then there are a number of what we're calling supplemental needs that are addressed as well, including individuals with disabilities, education and employment-related needs, family and community support, financial strain, mental health, physical activity, and substance abuse. And we've learned a lot about which of these needs is more or less frequent and which is easier or harder to address. Certainly one thing we've seen is that food insecurity tends to be the most common need, and that the easiest need to resolve, as reported by our AHC awardees thus far, has been utility needs. think this data has been very valuable to us as we've been thinking about what it looks like for the INC model, for example, to develop a multidisciplinary care team around beneficiaries who have a number of parallel issues, and also what a bridge organization can and can't do to make a difference for these beneficiaries. So again, just a lot of lessons learned here. I do want to I'm going to talk just briefly about the screening tool, and then I'll come back to the case study so you can see there's a piece that has been published about the screening tool back in 2017. The screening tool is a critical component of this model, and it's a place where I would say we overinvested in terms of both time and money to really make sure that we had the appropriate tool in place for bridge organizations to use this model. I think those who are familiar with AHC will also know that that has been the source of some challenge, in part because this is a space in the industry that is changing so rapidly. Today, in 2020, there are many more options for screening beneficiaries and patients for health-related social needs than there were when the AHC model was designed. We also, of course, have a really strong interest in making sure that to the extent that we can standardize things for evaluation purposes, we do. And so building a standardized screening tool was one way to sort of control for any variation. I will share that we have also learned a lot about how important the process steps are around screening, not just the tool itself, but really the process that different bridge organizations and even different clinical delivery sites use for administering the tool. So that continues to be an area of significant learning for us. So with that, I wanted to jump into just one case study that we've been able to publish, and it comes from St. Joseph's Hospital Health System, which is a bridge organization in AHC. And I think it's exciting in part because their data, you can see here on the slide, have risen steadily over the course of a year, which is really significant. We haven't published broad data across bridge organizations, but these data are quite significant in terms of showing continuous improvement in building capacity and in just being able to deliver more and more screenings for new beneficiaries over the course of a year. I want to just illustrate a couple of things about why seemingly slow but steady progress is actually so significant here. In order to achieve these data, St. Joseph's had to set up processes in place to have sufficient clinical delivery sites and an increasing number of clinical delivery sites such that it could actually find and screen and refer to navigation the same number or more new patients that it hadn't yet seen in any of its other sites. One of the challenges that I would say we anticipated seeing and that we have seen is that once penetration into a community hits a certain level of, a certain saturation point, it becomes more challenging for bridge organizations and their sites to find new patients that haven't yet been screened. And so in some ways, the later efforts to find beneficiaries to screen and navigate are more challenging than the earlier efforts, even though there are more processes in place at that point, and ideally more clinical delivery sites at which to sort of capture patients, so to speak. But I think St. Joseph's has done a really fantastic job at getting the message out at various levels to both make sure that everybody understands how big of a priority this is for the organization and to identify places where different sites or staff are encountering difficulty executing on the mission of the model. So one of the things that we've heard from them was about the power of being able to use data and data that they could share across sites to really both motivate staff but also inform their internal decisions on things like staffing levels at different sites and where to prioritize efforts to try to grow and achieve more scale. And that, just at a high level, is a set of messages that we've heard time and time again, that it's really important to have a champion at the top who really makes implementing AHC a priority. It's also really important to be able to have and share performance data at different sites to guide staff's efforts and also to guide leadership's efforts about where to prioritize. So in the interest of time, I want to shift to the Integrated Care for Kids model, which, as I mentioned, was announced in 2018 and launched this month. The Integrated Care for Kids model is a child-centered local service delivery and state payment model. That's a mouthful. But what it's basically doing is two key things. The first is It is building multidisciplinary care teams around children and pregnant women who are at risk for developing significant health needs. And the second is each awardee is developing a state-based alternative payment model to help incentivize for the kind of care delivery that they believe will make a difference for these beneficiaries. So I like to say that as complicated as the AHC model is, the INC model is arguably even more complicated. There are 3 goals to INC. The first is to see broad performance on key priority measures of child health. The second is to reduce avoidable inpatient stays and out-of-home placements. And then the third is to create sustainable APMs for this community of providers. INC works across 3 main stakeholders. The first is the state Medicaid agency, which will be implementing both some of the clinical aspects of the model, in other words, the interventions, how those are going to work, and also will be building and implementing the alternative payment model. The second is the lead organization, which is the awardee of the model, the one that receives the funding, and will coordinate across all of the stakeholders in the model. And there are cases in which the awardee is actually the state Medicaid agency, others where the lead organization is a different organization that will be working closely with the state Medicaid agency. And then third is the Partnership Council, because at its core, this model is an effort in collaboration. The Partnership Council will have representatives from the state Medicaid agency, the lead organization, and many of the providers in play, as well as some of the other community stakeholders that need to be represented to help make sure that decisions are made by consensus. Hopefully you can see already why this model is so complex. I did also just want to note that, again, this model touches on a set of core child services that, as you can see, run across many different settings. And this is part of why collaboration really lies at the heart of what we are aiming to do in INC. So clinical care, including physical and behavioral health, but also care delivered in schools, in housing, food and nutrition use, early care and education, child welfare, mobile crisis response. I think there are some cases where juvenile justice will be involved as well. I really think that, it's early days. We have just started the INC model, and I think our awardees are extremely excited to start. But this model will require even more collaboration across many different sites and settings to try to improve outcomes for kids and pregnant women. So not much to report there because, again, it's still early days, but we are really excited to see how the INC model shapes up and how we're able to learn lessons from AHC that might apply to INC and its awardees as well. And I will just say one more note before I hand things back, which is we at CMMI are paying close attention to both of these models to really hear from our awardees about how things are going, about where they feel they're able to have an impact and where they feel like they're less able to have an impact, and are trying to really incorporate those lessons into any future work on social determinants of health. So thank you again for having me. I'm thrilled to be here, and I'm also happy to take any questions.